Hi, everyone. Welcome. We'll just allow people to join before we get started. Thanks for joining us today. We'll give it a few moments. My name is Alex McFedrin. Thank you, everyone, for joining us. Happy Tuesday to everyone. Good morning, good afternoon, good evening. My name is Alex, as I mentioned, and I work with EPI-WIN, which is a team out of WHO headquarters. Please feel free to introduce yourself in the chat. Today, we're here to discuss the second webinar in a series on documenting existing faith partner resources that can be repurposed for different health emergencies. We are really excited to have an amazing panelist, which I'll introduce shortly. If you need French interpretation, we have it. If you just look down in the bottom bar, you can click the little globe and you access French there. This will be live streamed to YouTube. I thought I started that, but I'm a bit challenged, so I'll check and see that it's working well. If not, we will upload the recording afterwards as well. Anyone who signed up for this through our newsletter and the registration for the webinar will receive the slides after. Feel free to use the chat, but if you have questions and answers, we have a good amount of time for that at the end of the webinar, so please use the Q&A function. And that's easier for us to process as we go along. So as I mentioned, this is about existing resources, and today's theme is on stigma and discrimination. As we know, stigma and discrimination have really important and sometimes very detrimental impacts on health outcomes, as well as isolation, mental health, and so forth. So today we're here to talk about stigma and discrimination and how we can all work together to improve our responses to it in various health emergency settings. I'm joined today by exceptional panelists, Christo Greyling, who's Senior Director of Church Partnerships from World Vision International, Nelson Otwama, Nelson, Executive Director of NEPAC, a national network that unites people living with HIV and those affected by HIV and TB in Kenya, and Jane Nganga, a national coordinator for the International Network of Religious Leaders living with or personally affected by HIV, the Inarella Kenya chapter, and Gracia Violeta Ross, who's program executive for the Ecumenical HIV and AIDS initiatives and advocacy for the World Council of Churches. We will be presenting with different remarks from the panelists and some short presentations that accompany it, and then we'll move into question and answer. So to get us started, I'm going to look first towards Christo and share my screen as well. Hopefully, let's make sure we can see it properly. So to Christo, you will be discussing Channels of Hope, which you were a co-creator of the methodology. It was designed in response to the HIV crisis in Africa. Can you describe the tool to us and the key principles for its application? Over to you, Christo. I can't hear you if you are talking.
There you go. Thank you, Alex.
Yeah, there you are.
Yeah, the origin of this was actually in the midst of the AIDS crisis in South Africa and Namibia. When I disclosed my HIV status, the response that I got from one of my elders was, you know, we've got sympathy for you because we know how you got it. You got it innocently as a hemophiliac, but those people, they brought it themselves. So for me, the stigma that was associated with HIV, with blame and judgment, coming from faith leaders who actually should understand forgiveness and grace and compassion, was really something that I felt we should be addressing. And because I believe that faith leaders and faith communities are the place that should be the place where people should be embraced and feel safe. But we realized giving them just the information is not going to provide the answer. So it led to this process, which evolved over time. So next slide, Alex, please. So how this actually really works is that we realized just information, so working with the head only, is essential to have the correct and full information. But that's not going to change stigma and discrimination. So you need to also work with head and the heart before you can get to the hand. So that means that we need to start to help to experience how they actually have stigma themselves and talk about that, to kind of step into the mud and realize how they can actually need more information. Listen to the stories of people that's been infected or affected by HIV. That's how that started. And in that process, then link them to practical connections in the field. So if you go to the next slide to get us to the hand side, the whole workshop is laid out between this constant swinging between head, heart, and hand, starting with whatever, HIV and me, Ebola and me, and to where they struggle with some of the stigma issues. Then they realize they need the more information, that's the knowledge, moving to living with realities, where they're exposed to the realities people experience, and to listen to those stories. And that's where the heart starts to knock back, and then link it back to their faith and say, what does my faith say about this? How does I respond to it? To bring the ethical, the scientific, and the realities that are in the field together. And then out of that, go to the hand side and say, how can I engage in meaningful engagement in my own community and towards becoming a person competent to stand for that. So next slide. So in the Channels of Hope process, we constantly also look at the set of competencies about leadership, about care and support, prevention, community interaction, and help people to say, if you really want to be a channel of hope, then you need to grow in these vulnerabilities and help them to do that. Next slide is that in this process of Channels of Hope, we are linking them very strongly to a set of guiding principles that are faith-based. And that was some of the key aspects that we've learned is you cannot help people to just move by giving them just the information and expose them to realities. If it's people of faith, and you need to link them to their own faith and their own guiding principles. These are the Christian ones, but we also have for Muslim context as well, where we want to link it to scriptural references from their own scriptures to say, if you want to respond to this issue, then we are called to stand up for justice, or to accept like Christ accepted, or to speak the truth in love, and to recognize the equal worth of every human being. It's all linked to scriptures, and that we constantly go to that. Last slide. And in that process, then we also realize that you can't just do one event and think that will work. So Channels of Hope works with a process from training of facilitators, but then a workshop with follow-ups, where there's congregational engagement, further planning, and follow-ups and capacity building that build on that. And that's the lessons we've done.
Thank you so much, Christo. So Channels of Hope, developed by World Vision, is our first tool that we've looked at, and we're going to come back around to discuss it more. Now I'm going to shift to the next tool, which is the Stigma Index, and turn to Nelson. So in your role as Executive Director for NEPHAC, can you share more about how the Stigma Index is utilized to address stigma and discrimination in the global epidemic of HIV and AIDS? And please let me know to move forward on the slides.
Thank you very much for inviting me, for having me in this tool. I need to start by saying, I know I put my name in the chat, but my name is Nelson Otoma. I'm based in Nairobi, Kenya. I work with the NEPHAC, which is a national network for people living with HIV in the country. And talking about Stigma Index is a tool that we adapt from the global network of people living with HIV. So it's an elaborate tool. So today I'll just give a just a brief bit of it, but we can continue to talk about more details and even the tools to roll it out. So next. So as I've said, the Stigma Index is a standard tool for gathering evidence and the impact of HIV stigma on persons living with HIV. As the previous speaker talked about it, sometimes it's not just enough to put commodities to test people and to give them ARVs, because with stigma, people will not come forward to take them up. So we use this standard tool to document the experiences. And what is important to say in this slide is that it is anchored on the principle of greater involvement of people living with HIV, GIPA principle. And that means that we empower support groups and peer HIV networks to be able to implement the Stigma Index. Next. In terms of purpose, we have around 4 areas that we consider before rollout of PLHIV Stigma Index. We measure and then we quantify. We know stigma is a qualitative aspect, but we have a way of quantifying stigma and discrimination. We measure and then document stigma and discrimination and develop evidence to support strategies and advocacy. We also use this tool to describe the stigma and discrimination perceived by persons living with HIV. And if we go into detail, we'll know that there is external stigma and internal stigma. Some of it is based just on perception. We also use the tool to provide evidence for informed advocacy and also to ask governments and partners on what policy or laws to change, especially the laws that discriminate. And then lastly, we use it to broaden the understanding and the extent to which forms of stigma and discrimination exist and affect program uptake. Next. Yeah, so I was asked to briefly just talk about the importance of this. And what is important is that it monitors HIV-related stigma and discrimination across different domains of life, whether workplace, healthcare setting, with the community, in learning institutions. In doing this, we pay particular attention to stigma that is related to different parts of population. So some go to men, some go to young people, some go to key populations in their diversity. And the Stigma Index also provides evidence for advocacy to address key barriers to HIV treatment, prevention, care, and support. So sometimes as you discuss with the people, you also reach out to healthcare workers to find out their perspective on an issue, and also you work together with the person living with HIV to make sure that they overcome the stigma or the perceived stigma and access services. When we talk about PLHIV Stigma Index, which is different, an abridged version of PLHIV stigma, when we say 2.0, we mean that it takes cognizance of the fact that HIV-related stigma and discrimination may hinder uptake to access to other health services other than HIV. So somebody may fear going to a facility to be tested for malaria or for diabetes or for kidney problem, because for like women who go to facilities, there's a mandatory testing for HIV. So that is an hindrance, and because they fear and they have the stigma. And also the tools can be adapted to use in other settings upon request from international partners. In this case, we are talking about global network of people with HIV and UNAIDS as partners. And also it is important to say that initially this was purely for people living with HIV, but at the moment there is consideration for key populations that include sex workers, men who work with men, or people who inject drugs. And particularly those living with HIV, and even if they're not living with HIV, this tool can be useful and can be adapted. So I just wanted to keep it that simple, and I'm happy to get back and respond to questions if there are. And in continued discussion, then we can have more and then start to talk about the results, the PLHIV Stigma Index. Thank you very much for having me.
Thank you so much, Nelson. Really quick, you guys are very much on time, so that makes my job easier. We will come back and have more time for discussion, as Nelson mentioned. So I've seen a few questions come in. So if you have questions as we go along, please put them there. We'll come to them in the next section. So now I'm going to turn to Reverend Jane to discuss the Framework for Dialogue, which is a tool that builds off of the Stigma Index. So as the National Coordinator for Inter Rel Plus in Kenya, we're interested in hearing your experience conducting the Framework for Dialogue. What lessons have you learned? And could you outline a little bit about the dialogue to us? Thanks.
Thank you so much for this opportunity. I'll be discussing the framework for dialogue between religious leaders and people living with HIV. And as you have stated, it follows the outcome of the Stigma Index and gets us to the next point. Next. So just a highlight about the international network of religious leaders living with or personally affected by HIV. We engage at the congregational level, and we deliver our programs through our network of religious leaders through what we call congregational response. And our work revolves in equipping, educating, and building the skills and increasing knowledge of religious leaders so that they can become change catalysts in the communities where they serve. Next. The reason why we feel, so important for the engagement of religious leaders, not only in HIV, but even in, pandemics and any health or emergency that may come about. We know they have the extensive experience, they have the knowledge, they have the reach, they have the passion, they have the influence, they have the trust and confidence, and they also control social capital. It's only in a church that a faith leader can tell even a president to kneel, and they kneel in worship. And that's a kind of influence that religious leaders hold. Next. So the framework for dialogue methodology, it is a methodology that picks up the evidence that has come from Stigma Index or from any other context and leads to dialogue, and that dialogue leads to joint action. And it is one that strengthens partnership to end stigma and discrimination, and also leads to access to HIV-related services by all, because through the dialogue, you're able to identify where is the challenge and is able to build up advocacy initiatives that can lead to increase in services. It is also based on actions for ending stigma and increasing access on evidence. And therefore, during the dialogue doesn't just end there, but there are joint actions that are formulated, and together religious leaders and people living with HIV pick up those actions, and implementation is guided, and ultimately there are results that come about. Again, the other bit about the framework for dialogue is that it looks at evidence of Stigma Index from a faith-based lens. And that analysis of the Stigma Index reports helps to see where is stigma coming from or emanating from, specifically from the faith-based sector. And from that lens, then faith leaders are able to see how initiatives can be come about, or how they can do initiatives that would lead to ending stigma. So summary of it is that it's evidence, it's dialogue leading to joint action. Next. So this framework for dialogue, it is joint action, as I have said, which leads to ongoing discussions between religious leaders, faith-based organizations, and also networks of people living with HIV. And it was steered initially by 4 international partners, Ecumenical Advocacy Alliance, the GNP+, INERENA, and UNAIDS. And the purpose of it is to increase systematic, inclusive, and sustainable dialogue and collaboration between people living with HIV and religious leaders, both at national level, local level, but also at the national level. It has been piloted in a number of countries. It's not just the 3. Many more have taken up the framework for dialogue, and it is a tool that is really working to reduce stigma within faith communities. Next. Those are the core principles that are stipulated. It is country-owned, so when we are looking at the Stigma Index studies, you're looking at evidence at the country level. It is also has the core principle of being evidence-based. It creates safe spaces so that people can dialogue, and therefore you are able to dialogue with different vulnerable groups. It is action-oriented. It looks at innovation. so that we are not just doing things, the way we've done it before, but looks at what new thing or how do we think outside the box to ensure that we are becoming innovative. It offers equal opportunity for all in terms of engagement in the dialogue. There is no one who is, greater than the other. Everyone has equal opportunity, and it is also people-centered, and also takes very keenly the principle of doing no harm. Next. So some of the outcomes we have seen through the application of the framework for dialogue is that it goes beyond just the conversations on HIV, but opens up other issues that are underlying that could be leading to vulnerabilities among people living with HIV or the community at large, and interventions are able to, created from there. So the other thing that we have seen is that after the dialogue, it becomes very easy for religious leaders to integrate HIV issues in sermons. Some of them have ended up, opening up doors for support groups within congregations, some setting aside every month on Sunday for dissemination of HIV messaging within the church bulletins. Others have gone further to hold county dialogues or even congregational dialogues and having, working groups that would continue initiating dialogue. And then it has also helped to really identify some of the joint advocacy initiatives that can be done. For example, when we held a national dialogue here in Kenya, we were able to realize that the issue of access to viral load, machines was a key issue, and religious leaders were able to pick up that advocacy issues. In other areas, it has led to fundraising initiatives at the country level and conversations beyond HIV to really looking at sexual and reproductive health and rights issues to do with the GBV and many other issues as the dialogue ensues. So I want to stop here. I will be coming later to discuss some more about it. Thank you so much.
Thank you very much, Jane. So that's the third tool we've looked at so far, Framework for Dialogue. Now I'm going to turn to Gracia from the WCC. As an advocate living with HIV and a survivor of gender-based violence, we're interested in hearing more about the methodologies which are used to address the triad of stigma, discrimination, and violence in Latin America. Over to you, Gracia.
Yeah, good afternoon, good morning, everyone. I am now working in the World Council of Churches, but this experience that I'm going to present comes from the networks of people living with HIV, particularly women. The beginning of violence is always a stigma. When we don't respect the other human being, then we are more likely to commit violence against that person. Can we go to the next one? So why do our bodies matter? Our identities, I'm an anthropologist, are based in many facets, but body and embodiment are essential parts of our beings. We use our bodies to live our gender, sexuality, to reproduce, and to relate to other human beings. But unfortunately, in today's world, our bodies have been captured by the industries of beauty and health. And also our bodies can be attacked, stigmatized, violated, and we can get sick and age and die. So this methodology started in 1987 for studying fertility issues, but in the last years, it was used among people living with HIV. In the beginning, it was used to be a therapeutic tool and to even analyze how to die peacefully, because people with HIV didn't live, we only died. But in the last years, it was used as a mechanism to create embodied awareness, to tell stories about ourselves, to represent social relationships, and to translate knowledge, educate communities, and start holistic healing, and also do political activism. I'm going to present the next one. Two maps that are only two, we have many, but these two maps were done in Bolivia. This was done by a woman living with HIV. She was asked to to express what is the impact of HIV in her identity. So you can see in the central part of her body, he draws like these little animals. This is HIV, and it's also human papillomavirus that has taken hold of her health, and she couldn't have a baby that she wanted. That's why she's crying and she doesn't have a face. And we got these maps analyzed by a psychologist, and the psychologist said that the thick borders in the map express an attempt of the woman to establish a limit with an environment that she perceives aggressive to her. And the fact that she is not standing on the ground means that she might be trying to get out of the reality. So we can see the next one, please. The next slide. So this map is done by a network of lesbian women in Bolivia, and they were narrating here the killing of a woman who got pregnant by her family, her religious family. Bolivia is a very conservative environment. Didn't want the relationship because the baby, because she was lesbian, and they forced her to abort. And because of this abortion, this woman passed away. The network of lesbian women tried to put the case in the police as a homicide, but the family said it was a natural death, and it was even well received on heaven because justice was made. And on the central part of her body, they draw like a prayer that she had, because she didn't die quickly. She died in 2 weeks. If I am also believing in God, why was I killed in this way? This is the question this woman left. The next one, please. So what to do with these stories? You know, Bolivia, as many of our countries, are cultures that are dominated by anything that is male or masculine. And some of these politicians and policymakers will never read a report that we write about the stigma or gender-based violence. But when they were presented with these drawings, they saw it and they related to it, and they came and listened to the women. And not only that, they decided to take action. Some of these religious leaders that would never listen to a sex worker, because we also did the maps with the sex workers, decided to support the network of sex workers in order to stop gender-based violence. Although the methodology is called body mapping, it's actually, the mapping goes beyond the physical part of our beings, because the moment that we do these maps in a group and we interpret them together, we are creating awareness, we are healing together holistically. And this methodology has large potential to open and start difficult conversations, particularly those that are felt on the body and the feelings, you know, like gender-based violence, death, sexuality, gender identity, and race as well. This methodology puts people in the center and makes the issues that are not visible in terms of physical dimension visible to others, and also social aspects like poverty and spiritual feelings, you know, what are the beliefs of this person who is drawing the map. When people do the body maps and interpret them together, there is an effect of equality that is created. Policymakers and religious leaders who would never read a report, they also have their own stories to tell. And I just wanted to remind this idea that I said in the beginning. Violence starts with the stigma, and if we don't control the stigma, then it escalates to violence. I think there is one more slide. Well, I wanted to leave you with this verse from the Bible. It's in 1 Corinthians 12, chapter 12, verse 26. If one part of the body suffers, every part suffers with it. If one part is honored, every part rejoices with it. So this means if there are women who are living with HIV in our congregation, or women who are doing sex work, because there are, or women who are lesbian and they are suffering, the whole congregation should suffer. And that's the meaning of compassion. Thank you so much.
Thank you very much, Gracia. It really well demonstrates the seriousness of stigma, and that we need to take it into consideration all the time for the health of everyone. I'm going to go back now to Christo, welcoming you to add questions for our speakers to follow when we talk more about these tools. So Christo, back to you. Just like the framework for dialogue and a stigma index, the Channels for Hope tool has been used effectively to address stigma and drive positive health outcomes. Could you tell us a bit more about how Channels for Hope was adapted for the Ebola and COVID-19 response? And what key lessons have you learned after more than 2 decades partnering with faith communities to address stigma?
Yeah, good. Well, firstly, let me start, Alex, by saying the important thing that we started to realize is that you need to start where people are. That's the critical thing that we started to see is you need to listen where the needs are for people to address them. Sometimes we recognize from different perspectives that there are a stigma, but and sometimes we don't even know how to address that. But the community does. And that's for me one of the key aspects is that we need to build trust in communities, and it's based on that trust that you can relate. What happened with Ebola? Let's start with that. We had the Channels of Hope methodology on HIV, which addressed stigma. We did it with maternal and newborn child health. We also did it with child protection. So we knew that you need to kind of zoom in on the issues that are being raised in the community. But when the Ebola crisis came up, we wanted to respond. We sent the people in Sierra Leone a whole fact sheet that translated the World Health Organization's material into more local language with a few faith applications around it. But we didn't know whether we should actually develop something further. And while we were still struggling to know, should we not, do we invest in it, is it worth it? The next thing we heard is that the faith leaders in the communities, Muslim and Christian, together started to exchange material, visited each other's mosques and churches, and used that little simple 4-page document, and they called the Channels of Hope for Ebola. It wasn't it, but because they already trusted the content and they trusted the methodology, they started to do something. And then only we could start to jump to respond to that. But coming back to the trust issue, what we saw is that the trust in the community during the Ebola time was driving some of the stigma. The faith leaders in the community wanted to honor their faith traditions, and therefore that led to some ways of hiding some people. Parents didn't want to want to go to work, even they said the rule said we shouldn't, because they didn't want their children to be hungry. Examples like that. But the moment the World Health, where the government started to send in people, it was strangers. It wasn't people that they related to or who they trusted. And we know that in communities like in Africa, where 80% that faith leaders are trusted far more than government leaders, that was exasperating some of the stigma issues. So in developing issues that addresses stigma, you need to rely on what the community tells us, and that builds on the trust that they have already within their own community. So whatever we want to offer as methodologies to address these issues, we need to put people first and not come with our own. The second part around that is that inappropriate messaging kills. And I think we saw it very clearly with HIV, that all the wrong messages of AIDS kills and so on was detrimental for that. And the same thing was emerging with other disasters and emergencies like with Ebola and COVID-19, with the vaccine resistance, with the resistance against the messaging about Ebola. And with the help of faith leaders, we knew that coming alongside them again and creating a safe space where they can struggle with some of these local issues that they see in their communities, combined with the correct information provided by WHO, and then link it with appropriate messaging in terms of theology. That was the things that provided the local faith leader the tools in his hand to come up and come with appropriate responses in their communities. And lastly, the international faith-based organizations, I think that's for me a key thing that we've learned is very often the government don't have necessarily the trust in some of the communities where the faith leaders are. And the same we can say with some of the unilateral or bilateral organizations. They might want to come and work with the faith leaders, but they don't speak the same value language and don't understand the language of faith that well. While faith-based organizations internationally might already have those trust relationships in those communities and the tools. And in this case, Channels of Hope was one of those great examples where we learned you don't always need to develop a full new tool. We can come with a methodology, just an aspect, a modules that will address the issues that are necessary for that specific emergency that comes up. But the importance of having faith-based organizations drawn into the response team that have these tools and apply that is an important. I don't know if I've got a next slide, Alex, otherwise I can stop there. Yeah, let me stop there.
Thank you very much, Christo. I think what Christo spoke about just there at the end is really at the heart of this series of webinars, is that we have so many existing tools that are fantastic, and it's about learning the lessons from them so that when we apply them, they can be better fit for purpose, but also adapted to different situations. So we will discuss that a little bit more. I'm going to turn to Nelson now for your second round of remarks and to ask you similarly, what are the lessons learned around the Stigma Index and how it can be applied to different health emergencies? Over to you, Nelson.
Thank you very much. As I said before, I think the most important aspect of the PLHIV Stigma Index is that it is both its process and the outcome. Whereas it started out as something that you can use in research, we realized that it is not research, it is dialogue, and it ends up creating dialogue with the communities, particularly people living with HIV, and asking them what key considerations can they put in place to make sure that they overcome the persisting high-level stigma, and also talking to people openly living with HIV, what steps they went through to make sure that they were off stigma, and to start talking even in the media out there. And in that dialogue, then people get empowered to start talking. So this is something that is important to break the silence, the fear, and the anxiety that come with HIV infection, and therefore very important in terms of getting communities to have a discussion on very sensitive topics like living with HIV or when they got infected and so on and so forth. So I think the tools are flexible and applicable in other emergency settings, even outside the health, so that people, even though they may be facing other challenges like hunger or maybe displacement or migration or some other calamities, they can still afford to talk about sensitive issues. And why this is important is because HIV infection is lifelong, regardless of where you are, and you need to always be on treatment. And to be on treatment, then you need to be open. You need to go, if you are displaced, to go to a facility and introduce yourself and say, I'm a person living with HIV and I need to be on treatment, which is sometimes is not very easy. So those are the tools that come in to empower communities so that in whatever situation you are in, you are able to continue with your life and you are able to continue to break the silence. So it is the communication bit of it, and it is also the dialogue bit of it that is very important. Thank you very much.
Thank you so much, Nelson. So I'm turning now to Jane, and I'm curious to know, in the same vein, for the framework for dialogue, what kind of adaptations do you think are possible for it, and if it's applicable to other emergencies like COVID-19?
Thank you so much. And indeed, the framework for dialogue can be applied in any context, because it really starts by looking at what is data saying about an issue, and provides for a very systematic way on how that dialogue can be done. The other bit about the framework for dialogue, and it's a lesson that probably can be applied in other contexts, is the fact that it brings together, you know, different stakeholders, the government, it brings together the community, it brings the religious leaders, and anyone that would be affected by the specific issue. And then people are able to dialogue and really figure out who can do what. So, and we know that, for example, for faith communities, they are mostly at the first line response during emergencies. And the fact that faith leaders are available at any context in the rural areas, and you'll find a church or a mosque at whatever point, then it really helps in bringing people together. And of course, also you find that when there are emergencies, people run to churches, you know, for support and for help. And that can really help in terms of kickstarting the process so that you get to know what are the real and felt needs that the community has. And, you know, start by addressing those even as you progress to the others. As I said earlier, it provides and has articulated very clearly the roadmap that would lead to the dialogue, and therefore it can be easily adopted in whatever context. And specifically during the COVID-19, we employed the framework for dialogue in different parts of the country, and the conversations around the myths and misconceptions that were there around COVID, including the COVID-19 vaccination, then we were able to really dialogue both with religious leaders and the community. And specifically, we came up with a call to action that also involved faith leaders at the regional level, that is the African region, and the Ministry of Health and other players. And we were able to really employ the dialogue process to come up with this call to action. The other issue or the other lesson that we have learned is to interrogate evidence that, you know, that is available, the data. What is data saying? And as long as there is data, then dialogue can ensue, and therefore linking the action to data is very, very important, because sometimes you find people just coming up with the actions which are not well informed. So with the framework for dialogue, data is very, very important. And then it has provision for formation of necessary structures for response, so that, you know, the kind of support or the response, then it is well, you know, governed. Because sometimes there can be the haphazard way of, you know, getting involved when a pandemic or epidemic has happened. But then now with the framework for dialogue, it spells out, how do you formulate a working group? How do you ensure that it is inclusive? How do you ensure that it is responding to the issues? How do you dialogue about the very specific issue? And then the other thing is that we have learned is that with the dialogue or with the framework for dialogue process, it allows for prioritization of immediate actions which are most pressing, and those others that can wait and be dealt with later, and therefore helps in context where there are emergencies, for you to be able to spell out, because you're working with the community. It's not deciding from some boardroom or somewhere. You're working with the community and dialoguing with the community. So it's quite applicable. Then the other lesson that we have learned is the bit of development of the joint actions, which enhances collaboration. And that collaboration is very, very important in any emergency situation, because as long as there is collaboration, the suspicion, you know, sometimes there's always a suspicion. For example, even with COVID-19 vaccination issue, there was a lot of suspicion, but maybe had there been application of, you know, dialogue and utilization of data to inform dialogue, then it deals with that suspicion. And of course, also helps with the collaboration, helps in monitoring and learning and unlearning as the situation unfolds. And this can be employed or applied in whatever context of an emergency, and in whatever context that an emergency has happened. So those are some of the lessons that we have learned. And I believe it's quite an informative tool. Thank you.
Thank you so much, Jane. I think this is incredible to see how much we can use these existing tools to apply to many different contexts. Before we go to question and answer, and please keep populating the question and answer, I'm going to go back to Gracia. I'm very curious to know how the body mapping methodology can be used for any disease, and especially how we can bring the voices of those living with the disease to the policymakers and faith leaders. Over to you, Gracia.
Thank you so much. I was reading some of the questions, and some people were asking, how do we bring the battles? How do we unite? So there is a different story when in a community gathering, we receive a visit from an expert from Geneva, and they tell us how to live our lives. I have been in that position, but we don't need that because we have all the knowledge, we are the ones who are living with HIV. So this methodology of body mapping is bringing our knowledge into a document, which is this drawing. It might not look like a written document. For many people, for many scientists, they will say, oh, that's not a document, but it is a document. I am an anthropologist, and this is like a picture. This is a testimony. So it's bringing the voices of people who are living with the diseases to the center. We know what works. We know where it pains. We know what can be improved. We know how the health systems are there or not. So this is one of the best parts of the methodology. The other is that it's a fast and cheap methodology to bring these voices to the table. Sometimes in health emergencies, we don't have time and we don't have money to do long surveys like we would like to do. And so this methodology gives us quick information from the community who are there suffering with a disease. And also someone was asking about a conceptual framework for stigma. I would point you to Irving Goffman, the book of Spoiled Identity, and also the books that he wrote about psychiatric centers, which you would find incredibly similar to HIV. And then we will analyze in those two books that stigma sometimes, or what we call internalized stigma, is a means of defending ourselves from a context that we perceive very aggressive. Some stigma is solved with information, but other stigmas are not solved with information. And in that case, we have to use methodologies that speak about power imbalance. So why some people continue to stigmatize, although they receive the right information? It is because they are holding to some power privileges. So this methodology can be used in any situation that has something that we will live through ourselves, and that's everyday situations that happen to us, how we live in our neighborhoods, how we experience a pandemic like the COVID-19, how do we live the experience of going to the local hospital that we are attending, or how we live, I don't know, problems of abortion or rape in the neighborhood, or contamination of the water sources of the neighborhood. All of these situations can also be benefiting with this methodology, and people, their voices will come to the table of discussion. Thank you.
Thank you so much, Gracia. Okay, so we're going to turn to the question and answer, and I see that our presenters have been very active in answering a lot of questions, but I do think some of them, it would be great to open up for more discussion. So if you can turn on your video to all the presenters, and the first one is going to move a little bit on. I would like to address what Gracia was just speaking to about these different frameworks. I'm just going to find the question that discusses it, and I'd love to get everyone's take on it. So the question was originally from William, and he says, from my position as the chairman of the International Association of the Hepatitis Task Forces, we have found that the social justice issues of discrimination are the underlying causes of stigma because they impact the individual's job, social standing, financial, and psychosocial concerns. This demands humanitarian and religious efforts to spread compassion and equity. Over the last 25 years, we have seen this as a global problem. Behavioral changes and education are necessary moving forward through storytelling and other methodologies. So I'm going to open that up to all the presenters. I'd love to have your take, each of you, on that from your wealth of experience. So maybe I'll start with Jane, and then we can go to Nelson, then Christo, and then Gracia again. Thanks. Go ahead, Jane.
Thank you so much. And indeed, stigma, discrimination is such a pain. It is such something that we continually need to address, because it surely affects, many aspects of one's life. And I think for the important thing is first to know where the stigma is emanating from, and then be able to address it, because sometimes you find people stigmatizing because sometimes they don't know whether they are stigmatizing. And that's why we need to apply some of these tools to ensure that we are really addressing the issue, and we are also engaging the relevant parties that are stigmatizing. If I take, for example, in our context here in Kenya, initially, religious leaders were known and bashed for really stigmatizing people living with HIV. But now, having dialogues with the people living with HIV, there has been even instances where religious leaders have given apology on behalf of the people living with HIV for the kind of stigma that was pushed towards them. And therefore, what I'm saying is that applying tools, or the necessary tools to address the issue, is quite important, and really bringing the parties together so that there is common understanding of what and the impact the issue with stigma and discrimination brings to an individual, and really journeying together. I think that's quite important. Thank you.
Thanks so much, Jane. Over to you, Nelson, for your reflections. Oh, you're on mute.
Sorry for that. Thank you. I need to start by saying that long before HIV came into the world, there was stigma. And HIV just came to reinforce the stigma that was already existing. And I think what we need to know is that human beings tend to want to say that they are the best. So because we want to say we are the best, we Christians are the best, we Muslims are the best, we white are the best, we black are the best, we men are better than women, we need always to find reason why we are the best, better than the other person. So that is the origin of all this, that we are better. We are better because we don't have HIV. We are better because we are Christian. We are better because God loves us. And because that, combined with the lack of knowledge, also comes then to reinforce stigma. And then the second bit is what Violeta was talking about. We tend to compete for space, for resources, for attention, for everything. And we need that attention. Why would you focus on people who have HIV and we are here, people who don't have HIV? So those are the issues that are there to come in. And then now they reinforce by the infection around HIV. So I want to agree that they all lead to injustice in the health arena, and we need education. We need to educate communities, we need to educate healthcare providers, and we need those who do HIV programming. And we also need to educate those who do HIV funding, because in Kenya they come, whether they are Global Fund or PEFA, they fund ARVs, but they don't give their money to fighting stigma, for example. So fighting stigma is something that people don't think is important, because it is social, it is qualitative, and you don't quantify. And quantifying means that you can count how many people in Kenya have taken ARVs, but you can't say how many people in Kenya are suffering stigma in various facets. So what is important is to continue to intensify that education and to stand with people who have HIV, who have gone public, to break this stigma, and then apply these tools we are talking about today to other conditions and other diseases, like the stigma index is now being applied for TB. Thank you very much.
Thank you so much, Nelson. Christo, over to you.
Well, our person who asked the question specifically also refers to storytelling. And I think if we look back on the whole journey with HIV and what turned the tide in terms of HIV stigma, it is also the availability of people living with HIV who was willing to risk to tell their stories. it is then that HIV got a face, where it was not just some things that people were talking about, but that people had to listen to the pain and the joys and the future looking for of people living with HIV. And to talk about what causes stigma and how that stigma impacts was the thing. And I think as we look now at the stigmas around us in terms of LGBTQ, race, and all these things, that's still the reality in our community. It is still the storytelling that, combined with the correct information, combined with the ability or the empowerment to respond in communities, and the correct theological application. But at the center of that is, you must get a face and an understanding of what is this thing doing to people. And in that's where the change starts to happen. But you need that safe space where people can tell their stories.
Thank you, Christo. Gracia, back to you. And I know you were answering this one in the chat as well, but if you'd like to speak to it so everyone can hear your answer, that'd be great.
Which one was it?
We're discussing from William.
Social justice, the question of the person of the hepatitis.
And you were speaking about embodied awareness in a framework of action oriented.
So when we use these maps, which could also happen in a support group of people who have cancer, for example, we come to realize the power that is in us when we are together as people who are living with a disease or people who are living in a gender identity or a sexuality or a race, ethnicity. So that awareness becomes something that we can feel on our body, and that's what they call embodied awareness. But also it's important that we use this framework of action-oriented research and political action. We don't need the Ministry of Health to come and organize us. We can do this for ourselves. And when we come together and open those safe spaces or safer spaces that my colleagues were saying, we will see that the people immediately will bring also ideas, strategies to solve the problems that we are analyzing together we have. Now, we will always need to use the help of existing networks. It could be the network of people with HIV, the network of LGBT communities, the network of women who are working for women's rights, or young people who are already doing something, because they are going to help us on bringing our demands to the policymakers. And now, churches, what they can do in relation to all of these. Churches don't use so much the language of human rights, but they understand very well the language of human dignity and compassion and love, and we should use this and ask the faith communities to support our struggles. It is not that they are going to start a struggle for us, but they are going to support what we are doing, because it's a matter of justice, and faith communities have the moral obligation to be on our side, because this is what the Bible calls them to do. I know many churches are doing this, but many others are not doing this. So we can use the same text that they are reading in order to call them to join our battle. Like these women, I was telling you about Bolivia, some of the Catholic sisters, they would never agree on sex work officially. They can't, because they have this institution of the church which is never going to agree with sex work. But when they saw the maps of the sex workers, they decided to help the sex workers, because this was a matter of justice. And they identified themselves with these women. They were no longer looking at the sex work part, but as their identity as women, talking to other women. So these are strategies to join people on our battle.
Thank you so much, Gracia. I think that the important piece here is humanizing that every individual is going through their experience, and it's a real human life. And that's something that we need to think about from a faith perspective, from a health perspective, from the national government, from policymaking perspective, that each person who's experiencing stigma has massive ramifications for themselves individually. I wanted to shift a little bit to one more question for each of you, and then there's some specific questions about the tools, but one more question that came out from Andrew, which I would broaden to all of you, was about how interfaith initiatives are very vital and how maybe these tools have been utilized in interfaith context, so not specific to any one religion. Who would like to speak to that, or all of you, I'd welcome you to. Christo, go ahead first.
I'll start in the risk and fill in from the EHAIA side and so on. For the Channels of Hope process, we realized that the success of Channels of Hope was that it was faith specific. It wasn't universalist in the way of trying to speak something general to all faiths, because that doesn't speak to the heart of faith leaders who want an answer from their own faith perspective. So that's why these guiding principles that I showed earlier are linked to specific, for the Christian one, specific to scriptural verses from the Bible. But when we developed the Muslim version, one of the sheikhs that I showed this to initially, that was adapted by a Muslim scholar, he said, I'm afraid this looks like Islam. Now that is exactly what we don't want. We don't want something that's a wishy-washy kind of thing. It must be developed by authentic Muslim or Christian leaders that can do that. So in our case, it was co-owned. Some of our projects by Islamic Relief, they appointed the Islamic scholars that developed the Islamic content. And now this is a shared product that is being shared with us, with different, across different organizations, but it's also applied in different faith content. So at this stage, we, in terms of Channels of Hope, don't have a specific Hindu or Buddhist version, but we have some people who have started to apply that already. But the general principle is keep it faith specific.
Thank you, Christo. Jane, would you like to answer?
Yeah, thank you so much for that question. Maybe first to say that EHAIA is an interfaith organization. We bring together all faiths, and specifically in Kenya, we have the Christians, the Muslims, the Hindu community, and also the Baha'i community. And whenever we undertake even dialogues, it's usually on an interfaith platform. And that's how we've been able also to employ the framework for dialogue. Also to say that whenever a dialogue happens, there are issues that come up that will require theological reflection so that there can be a better understanding around it. And we've been able even to do theological reflection around the issue of stigma and develop specific tools that can be utilized by different faiths and can be applied, as Christo said, having the scriptures, because for faith leaders, utilizing a scripture is quite such a, a great key towards understanding and also sharing information. And therefore, we have been able to do theological reflection on stigma and gone further and developed guidelines, stigma guidelines for use by faith leaders. And this is on an interfaith platform, and it's really working well with the faith leaders. Thank you.
Thank you so much. I was wondering, Nelson, there's a question specific about the stigma index. What questions of the stigma index are related specifically to faith, either as a source of stigma or as a source of support for people living with HIV?
Yeah, as I said, we have a checklist and we have questions from the partners. And one of the questions is the experiences people have when they visit faith facilities and how they interact with the faith leadership, and whether they go to church or whether they go to mosque. And also how the pastor, last time they interacted with the church in a manner that they felt was stigmatizing. And I think with education, this is improving. But remember, for Christianity, the pastors, I think we want to call them those who probably don't read much. They like to pick chapters that really appeal to them, that are easy to pick. You go to Romans and they say, for the wages of sin is death. And wages of sin is death. And that is what they've been repeating. Wages of sin is death, and so on and so forth. So there are questions that you can tailor-make to specifically elicit experiences of people around the faith sector and the faith community. But I also want to agree with you that it is important to educate, to engage the faith community, because most people, when they are sick, they go to the faith leaders to pray for them. They also take care of orphans and so on and so forth. Thank you.
Thank you so much, Nelson. There's quite a few different questions. So if any of the presenters see something they really would want to respond to, please feel free. But I wanted to go to this question from Gabrielle. Do we have evidence that demonstrates the impact of what faith interventions have done in addressing stigma, and what works? Who would like to answer that one? What evidence is there that these faith interventions have worked in addressing stigma? I'm going to call names.
Well, I can speak from the Channels of Hope side. We started to do 2 research projects to actually address that. The one was done first already in 2007 in Uganda and in Zambia, to look at specifically the stigma outcomes of terms of HIV. We also did a longitudinal study on some of the child protection related channels of hope, where there's also a number of stigma about either the abuser or the abused person. And the results from that is available on our website. I'll make it available for you. So that was a longitudinal study over five years in 5 countries, which demonstrated the power of working with faith leaders in these issues. Also on maternal newborn child health. I will place it in the chat box.
Thanks, Christo. Over to you, Gracia.
I would also like to give some information about that. So recently, WCC with the Ecumenical Advocacy Alliance started documenting the experiences of churches, local congregations responding to HIV stigma, because we realized, the epidemic changed a lot and faith leaders have been doing a lot, but this has not been documented, unfortunately. So this study is going to be available for public revision, I think maybe by the first months of next year. In the first phase, it's collecting the stories of 7 congregations. Well, John is here. One of my colleagues is here. Also Manoj Kurian is here. He can also talk about the study. But we like to continue this study, documenting what local congregations are doing in simple terms in local communities, because we don't want to give the idea that this is super expensive so that no one can do it. It is not true, because changing stigma comes from the heart. A piece of it comes from the mind. In some cases you need like a budget information, but most of the cases, what you need is an attitude, a mental disposition to listen to the other person. I was looking at one of the other questions in the Q&A, and it says, all these issues have been always there. Yes, it's our mechanism of denial. In sociology, they study this a lot. We like to say, oh, the Spanish will give us the flu or the Dutch flu. That's how we used to name diseases even, because we want to think the other is going to make me sick, but I am not sick on my own borders of the country, or my community is not sick. Is the sex worker, is the gay man, whatever, it's a denial. So when we provide the right information, then people realize that we are all vulnerable to diseases, so therefore stigma has no longer reason to be. And in terms of HIV, the undetectable, untransmittable knowledge that we have now from WHO and UNAIDS, it's a powerful thing to defeat the stigma, because the main reason why people with HIV are feared even today is because we can transmit HIV. We could no longer, if we are undetectable, no longer. So what is the source of that stigma anymore? So we have to promote this you equals you a lot, and begin telling people, these persons with HIV cannot transmit HIV to you. Even if they wanted to, they cannot, because their viral load is so undetectable, so small that they don't represent any harm for the community and for anyone. Yeah, this is an important message that people don't know. You know, this is a response that we got from science in the last years, but it's not in the public knowledge yet. Thank you.
Thank you, Gracia. Very important. Over to you, Jane.
Thank you. And just to say that we started implementing the framework for dialogue in 2015. And in 2018, we did an impact assessment of the framework for dialogue and its utilization within faith communities. And again, this is a document that I can share so that people can see, you know, the impact that has come along the way. But just to mention just a few things that it points out to, one of them is the use of language. Because earlier, you know, faith leaders were not privy to the right use of language. For example, they would use words like victims and such. And now there is better usage of the correct language because people living with HIV were able to point out to, you know, specific areas. There has also been testimonies by people living with HIV saying that I feel now more comfortable in my space within a faith community because my faith leader or my pastor, my imam is more understanding and more available. There has also been the formation of support groups for people living with HIV in congregations. And again, that pointing to the fact that, you know, stigma is reducing and there is more acceptance, and in other congregations, just creation of that safe space where people living with HIV can meet comfortably, and even the church goes a step further, even to provide refreshments, and there will always be a faith leader who will come and start with a word of prayer, a word of exaltation before the support group begins. That also pointing to reduction in stigma. Again, the mainstreaming of HIV messages within, you know, sermons, within church bulletins, and within, you know, the many things that the faith leaders are doing, and even going beyond that during conferences, either youth conferences or specific conferences within congregations, assigning time so that there can be someone to talk about HIV and the provision of even HIV testing. That also points to reduction of stigma through the application of the tool. And in other congregations, we have seen also allocation of budgets to HIV and health. And I think that also speaks to, you know, the ownership and also the support. Thank you.
Thanks so much, Jane. I'm just going to call on John Blevins, who's joined us and is a colleague as well, and has given a really great answer already in the Q&A. But John, if you'd like to speak to it, go ahead.
Sure. I'll briefly just describe the case study that Gracia referred to and that I've been providing some information on in the Q&A. It was a congregational case study of 7 different Christian communities in South America, the United States, 5 different countries and 5 different countries in Africa, to understand how those congregations are addressing stigma in both among members of their congregation and among members of the community more broadly. I think we're finding out a lot of things from analyzing the qualitative data, and we will publish the final report on that study in early 2023. What I wanted to say really briefly, though, is that one of the key findings from that study is that the ways in which the congregations all described that stigma is contextual and multifaceted, and that when members of a congregation decide to address the stigma that they find in their community, or that they find a member of their congregation facing, it's in response to a relationship with people living with HIV, or a person or a group living with HIV. That doesn't mean that if they address stigmatizing attitudes toward children living with HIV, they become experts in anti-stigma efforts with people who inject drugs. That stigma is always contextual and multifaceted, and it's always a learning process. One of the things we also found from this study is that once congregations start down this road, they become much more willing to continue that journey of ever broadening of what they understand stigma, anti-stigma efforts to look like, out of a conviction that they're having the opportunity to understand more and more fully the fullness of God's love for human beings, and that they have an opportunity and a responsibility to make that love material and real in the world to more and more communities that experience stigma. We'll be sharing that document, and the academic consortium of the UNAIDS PEPFAR Faith Initiative is going to be working to carry out this work even further in this upcoming year in 2023 with additional congregational studies and a survey document that will allow us to create a resource directory to connect congregations with one another to find out how they can support each other in these kinds of efforts, and to expand beyond Christian congregations to temples, masjids, and other faith communities from other religious traditions.
Thank you so much, John, for stepping in. Amazing intervention. So we only have about 10 minutes left, and I want to give each of our presenters an opportunity to give some last remarks. So we'll do that now, and then I will summarize a little bit of what I heard, and then more about the series and next steps from here. So I'm going to start with Jane, if you'd like to start with closing remarks. Over to you.
Thank you so much. And indeed, it is such a good thing for us to be meeting and discussing some of the evidence-based interventions that we are undertaking, and also to see, the overplay of, each one of them. And it is my hope that we'll continue with these conversations and really looking at the impact that is being created, especially at the local level, the grassroots level. And we look forward to continued conversations and any information needed around the framework for dialogue, I would be glad to continually provide. Thank you so much.
Thank you so much, Jane. Christo?
Yeah, I'm just linking to what John said in terms of stigma is a universal human thing that is unfortunately part of our lives, and it differs from context to context and on issue to issue. But the openness that started to develop when a church group or a congregation or a person started to move on one issue, the likelihood of starting to move on others, they're more open towards that. So I want to encourage us to really continue to realize the role that faith communities play in many of our countries around the world, where they can help to bring about, as catalysts of change, that openness towards a society that embrace one another and rather than stigmatize one another. And that continues to place the emphasis on the need for faith literacy, not only on the responsibility of the faith leaders, but also faith literacy on the governments who needs to make decisions about where funding goes, as well as to the bilaterals and multilaterals who have to start to make the funding available. Without that faith literacy of the role of faith to be able to be the change agents towards the break of stigma on key issues in our communities, we will not be able to win the battle in the long run. But we can if we bring the faith leaders and the faith sensitivity around that.
Thank you, Christo. Nelson, over to you.
Thank you, and sorry that I changed my gadget so you were not able to see me, but I can make my last comments quickly. I think we are talking about HIV and AIDS, which the global community has committed to ending by 2030. And our country is part of that commitment. But the point I want to share here is that it costs money. Fighting stigma also costs money. So the partners, the donors who give money to HIV Global Fund, PEPFAR, it is not just about commodities, it's not just about testing, treating, and doing laboratories. It is not just giving money for ARVs and viral load taking. It also caring about the dialogue communities, the discussions we have here, the communication we have here. So I think it's point to reflect back and say that if they provide just money for commodities, not everybody will go for those commodities. But if they also take a small percent of their resources and put in community dialogues, even with the faith community, then we are going to win the war on HIV and AIDS. But if they just put their money on ARVs, it is very difficult. So I think this conversation needs to get to the donors. Thank you very much.
Very good point. Over to you, Gracia.
Yeah, I had the opportunity to sit in many global spaces, and in the last years, I have seen how HIV is being left behind. You know, it's not just some people who are left behind, but HIV, it's not a popular topic anymore. Some politicians think that HIV is no longer an issue, so why should they invest money, or why should they do anything with a disease that is supposed to be in the past? So it is our role, you know, those of communities and faith leaders, to keep HIV important in the global discussions and the national discussions, especially because it brings a lot of knowledge that we build based on the suffering. Many people died so that we learn what we know today. You know, the movement of people with HIV that I learned from, many of them are not here anymore. They are in the cemeteries, but their legacy is what I am holding on to. And the experts are telling us that this is not the last pandemic. So we have to prepare. We have to become like archaeologists, you know, taking the best of HIV and using it for COVID, for monkeypox, and for any other pandemics that may come in the future. And those are ideas that we can very much do, connecting this faith, stigma, healing, and pandemics with HIV. So this is an opportunity for us. I think we have all the knowledge that is needed. Maybe we just need to put it on writing, or maybe even talk about it. And I know people need this kind of knowledge. So I invite you to keep talking about this in your own context. Thank you.
Thank you very much, Gracia. So to finalize and kind of wrap it up, I first wanted to address that there are so many parts of this discussion we didn't have time to address. I know there was comments put in the chat. Gracia has an amazing comment in there about power. We have some questions that were left unanswered. There's the intersection with racism. There's the decolonization of health and in general, policies, laws. There's a lot to this topic. So first acknowledging that it is wide ranging, and we didn't at all tackle it in every way. We looked at 4 tools today, which is just scratching the surface of what's available and what's possible. And there's a lot of depth to each of these tools. So I really do invite everyone watching to take a look at them in depth and to reach out to some of our presenters to get more information. The purpose of this webinar is in a series from the WHO Faith Network, which was formalized earlier this year, in documenting what already exists, because there is so much knowledge, experience, intuition, and expertise within our faith partners and in the faith community that we need to look at and utilize and work together on. And I want to say, as someone who's just only recently started working with faith communities, it's been a real honor. And on behalf of WHO, I would really thank everyone for taking the time to be so participatory and to share their expertise. I think it's an important shift for us to recognize there's technical expertise, there's community expertise, there's faith knowledge, and it all really matters. And at the end of the day, if we want our world to be a better place, a healthy place for everyone, we need to work together. In terms of the tools, I think what we saw is the importance of lessons learned, that we develop these tools and we can continue to refine them and contextualize them as we go forward and adapt them. And lastly, I just wanted to say, I think for me, this was an exceptional reminder just to be kinder, not to be cliche, but at the end of the day, we all have that belief. We're all human. We all have hearts, and we want to be loved and accepted, and everyone deserves that. So as we go out throughout throughout our days for the rest of today and onwards. I hope we can carry that simple lesson with us, and that's a great reminder. The recording will be made available. We will put it on our EPI-WIN YouTube channel. Everyone who registered for this webinar will receive the slides, the recording, etc., and the access to the links to the tools. If you want more information about the Faith Network, you can email us. I'll drop our email into the chat now. But thank you so much for everyone who joined. It was exceptional. Your time and expertise is really important in the fight against HIV and AIDS, but also for protecting everyone who deserves love and compassion and respect at the end of the day. So thank you so much for everyone. Have a great day, and we look forward to talking to you soon. Thank you so much. Bye, everyone. Thank you.
Goodbye.